Thank you, sir. Thank you very much.
Request for the all panelists, can you please open your video?
Yeah. So I will be essentially requesting the coordinator to present my slides. Unfortunately, for some particular reason, my laptop is not working. So I think Gitika, can we move on? Yeah, I welcome all my panelists. This is, I would like to present two cases in this segment and one case in the other segment. We'll try to, try to discuss these points as quickly as possible, which essentially summarizes all the talks that were wonderfully given today till now. So this is about a 50-year-old gentleman who had no family history of malignancies, who had been complaining of dysuria and pelvic pain on and off for about 8 months duration. So he initially was evaluated by a physician who got an ultrasound scan done, which showed prostatomegaly with significant post-void residual urine. And for the back pain, he was referred to an orthopedic surgeon who did an MRI of the LS spine. And he noted that there were multiple metastatic lesions in the thoracic as well as the lumbar vertebrae. Subsequently, a PSA was done, which reported back as 17, and he was then subjected to a prostate biopsy, which reported a Gleason score of 4+4 and a classic acinar adenocarcinoma of the prostate. PSMA PET CT was suggestive of a extensive skeletally metastatic disease, along with multiple nodal mets as well. So he's a 50-year-old male with a metastatic prostate cancer. Next slide, please. So can I start with Amandeep? Amandeep, how do you want to proceed next?
Yeah, so this is Dr. Srikanth here.
Yeah, Dr. Srikanth, yes, please.
Yeah, so 50-year-old gentleman presenting with Gleason 8 and metastatic disease. So it's a hormone-sensitive metastatic prostate cancer. So I think the standard of care now is a doublet therapy. So ADT has to be given, and as discussed by Dr. Mahendra, we give all the options to him: surgical with medical castration in the form of agonist versus antagonist, and we have to add another agent which can be an androgen receptor modulator or chemotherapy in the form of docetaxel.
No, given that he is young, he is only 50, presents with extensive metastatic disease, would you be inclined to consider chemotherapy upfront, or would you start off with a novel hormonal agent?
So there is no head-to-head trials comparing about novel therapeutic agents like abiraterone or enzalutamide and chemotherapy. But given his high volume disease and young status, definitely I would offer him first chemotherapy first with a docetaxel, 6 cycles, like 75 milligram per square meter.
Dr. Gautam is there with us. Dr. Gautam, would you agree with Dr. Srikanth, or would you consider hormonal agent at the moment, or would you do something else?
Sir, I would like to treat him with ADT plus docetaxel plus abiraterone as per the PS1 trial, which has shown PFS as well as OS advantage over ADT plus docetaxel or ADT plus abiraterone actually. Since he is young and fit, he can well tolerate the treatment also.
Yeah, I think as we talked, the Arasens trial has also come out with its results, wherein they have added darolutamide in this segment along with.
Yes, sir. Yes, sir.
Yeah, and
yes, sir.
It has a both cancer-specific survival as well as OS advantage. So, but I think all of us definitely agree that he requires chemotherapy because he is young and his metastatic burden is quite high. Next slide, please. So, Dr. Rajesh, is this a patient for genetic testing? Would you want to do it now, or would you want to do it later?
I would like to do it now, sir, because later on the tissue quality, the blocks quality might come down, and yield might come down. So I would like to get it done now only. He is the perfect candidate, 50 years male with extensive metastatic disease. I would even like to get somatic as well as germline too.
So you get both somatic as well as germ. So you would essentially do a HRR mutational testing, which will include even the BRCA1 and 2, is it? Or
Yes.
would you like to do BRCA1, 2 separate and then the somatic?
No. HRR panel, complete panel I would like to get.
Yeah.
And
So
I would like to get the MMR testing also to look for microsatellite instability, immunohistochemistry.
okay.
So now I'll get it and keep it. Later on, it might be required.
Later, how often? I mean, in your practice, have you found microsatellite instability high reported in metastatic prostate cancer patients?
So far, from our institute, we have sent 10 samples for microsatellite instability. Only one we got positive.
I think that's a big number.
That patient was had colorectal malignancies previously.
Okay.
So case of Lynch syndrome.
Yeah. So yeah, that's the point that it's quite valid here. So if there is a strong family history of other malignancies, I think even MSI will play a major role even upfront. Otherwise, I think the yield with MSI positivity is pretty low. Dr. Gautam, do you agree, or do you have any difference in opinion?
No, sir. Completely agree with you.
Yeah. Next slide, please. So next slide. I think all of this have been very well dealt by Dr. Tejinder. So these are the patients who should ideally be tested by germline mutations. Those with a positive family history for cancer, regardless of age of disease. Those with known DDR mutations in the family, especially the BRCA2, and those with prostate cancer, even if they have a negative family history and have metastatic prostate cancer representation, or when they have a biochemical relapse after initial curative treatment failure, or even in those patients who have high risk or intermediate risk localized prostate cancer, and those with ductal or intraductal histology. This I borrowed from the NCCN guidelines. Unfortunately, the EAU and ESMO do not as yet support to all of these indications, but most of the guidelines do definitely agree that germline mutations are useful in younger patients with metastatic disease and those with a positive family history of cancer. Next slide, please. So this was way back in 2018, where we were still not having olaparib. So he was started on hormonal therapy with degarelix, and he received the standard dose 3-weekly regimen of docetaxel. In the post 3 cycles, his PSA came down from 17 to 2.5, and PSMA PET after 4 cycles showed a very good response. He did not have significant adverse events. So our colleague medical oncologist continued with 8 cycles of docetaxel and completed it in October 2018. The Nadir PSA at the end of chemotherapy was 0.9. He was continued on monthly degarelix. Next slide, please. By about another 6 months, so 1 year from the time of diagnosis, he started having recurrent urinary symptoms as well as lower back pain. His PSA was now rising from 0.9 plus 5, and by then we had initial data on the PROFOUND trial. So we repeated a TRUS biopsy of the prostate, which still showed active disease. It was sent for NGS testing to Foundation 1 because HRR mutational testing was not uniformly available in the country. The Foundation 1 reported ATM loss in exons 46 to 63. Dr. Gautam, now that there is a actionable mutation, how would you approach? We were talking of 2019, but I think it's more relevant to talk of today. So how would you approach?
So, it basically depends on the patient's performance status as well as the affordability.
Yeah.
And if the patient is affordable, we can start. There are basically multiple options like hormonal therapy, chemotherapy, and the olaparib also. So, depending after counseling the patient, we can start with either of these. There are pros and cons to each of these. There are certain side effects which we have to monitor, which we have to consider before starting the therapy.
Okay. So what would be your next choice of drug?
So, since olaparib is still costly, we would like to start with abiraterone for this patient, abiraterone or enzalutamide
Abiraterone
or
or
cabazitaxel, enzalutamide or cabazitaxel for
so
this
all
patient.
options are basically open, both the novel hormonal agents as well as the second line chemotherapy.
Yes, sir.
Yeah. Dr. Preetham, if you were managing this patient, would you consider giving him PSMA tag lutetium therapy or any one of those PSMA tag therapies right now, or would you want to reserve it to a later date? Because I think there now data from Australia to say that patient at CRPC is an ideal candidate for PSMA tag lutetium therapy.
So not right now, not upfront at this point of time. I would always want to reserve it at an where none of the therapy is working for him. So I would always prefer as a novel the second line of chemotherapy or the newer hormonal agents like abiraterone or the enzalutamide at this point of time, sir.
Dr. Gautam, how often have you found cabazitaxel to be useful immediately after docetaxel has failed?
Sir, it has worked quite a few times, especially the time interval between the end of treatment of docetaxel and the recurrence basically matters. As the time is long, the response is also better.
Okay, so so this year it was only a 6-month interval. So probably, like you said, you would probably consider giving him a hormonal agent rather than cabazitaxel, if that's what I.
Yes, sir.
Yeah, Dr. Saurabh, he has been having sacral pain constantly. So, what would be your indication to palliate the pain? Would you like to do the palliative RT to the sacral area and then start him off on the second line drug, or would you wait and watch for response with the drug?
So if patient is in pain, I definitely recommend to start with the palliative radiation, whether it is 20 gray 5 fraction or a 8 gray single fraction. That may help him to cover that for later. It will provide the stability plus pain control for coming 3 to 6 months. It will be a good response to the palliative form of radiation to that area.
Okay. Yeah, I think if the patient is in considerable pain, it's probably important for us to palliate the pain as well, because the medication systemic therapy in itself may not be really helpful. Yeah, can I have the, I mean, I think all of us agree that there is a role of olaparib right now. And like Dr. Gautam said, barring the cost considerations, he would probably look at olaparib. But since cost is on the higher side, he would go for a novel hormonal agent. Next slide, please. So this was discussed in the tumor board, and since he was having a progressive disease, it was and with a very low PSA even to begin with, because most of the medical oncologists in the tumor board felt that PSA of 17 for a metastatic disease with a Gleason of 4+4 was slightly disproportionate. So based on what we had from the foundation one, we went the medical oncologist felt that adding carboplatin to the docetaxel would benefit this patient, and that's exactly what was done to the patient. And following 3 cycles, patient seemed to clinically do well. His pains had gone down, his performance status improved, and his PSA came down from 5 to 1.2. So I wanted to ask Dr. Gautam here. Dr. Gautam, how often do you consider carboplatin in your...
So generally we don't start with the platinum, though it is considered if the patient is BRCA mutated or HRR mutated, they respond well to platinum. We use when we have exhausted all the lines of treatment, and if the patient is not affording for any other treatment options, we can use it. Here they might have used, because the patient has already progressed on docetaxel, and adding a platinum might make a sense. So that might have.
Yeah, this was back in 2019, but would you agree to this?
No, sir. No, sir.
So that's something that I really wanted to understand from you. So if there is an upfront indication to use a platinum agent, can you tell us which are those patients where you would strongly consider platinum right from the beginning?
So platinum is not as such recommended, but it can be considered for patients who are basically HRR mutated, because these patients generally respond well to the platinum.
Okay. Okay. And going back, do you think doing an IHC on a Gleason 4+4 to rule out neuroendocrine elements or so on and so forth is important, or when would you like to do an IHC to rule out neuroendocrine elements?
So basically, there are two types of neuroendocrine carcinoma which we encounter in day-to-day practice. Basically, there are pure neuroendocrine carcinoma and there is mixed basically. So the behavior of the tumor is basically dependent on the percentage of the tumor which is neuroendocrine component. So patients who are neuroendocrine component, they are independent of the AR pathway and they generally don't respond to the ADT, but however there is still a controversy to use ADT or not. So these patients are managed as per the treatment lines of the small cell carcinoma lung. So they are treated with platinum plus etoposide. And these patients are basically younger patients. They have low PSA at presentation and they have very aggressive disease also. So when we encounter these type of patients, we can consider starting platinum plus etoposide. And also when a patient progresses till the PSA is low, we may consider to do a rebiopsy.
Okay.
Transformation of the prostate adenocarcinoma.
Okay. Thank you. So subsequently, we did a PSMA PET CT scan, showed a good response. He was started on abiraterone. He is right now doing well, continuing to use abiraterone for almost 2.5 years now. Next slide, please. Yeah, I think I'll skip all this. Next slide, please. Next slide. Yeah. So this is the this is my second case. This is a 71-year-old hypertensive gentleman who presented with vague abdominal symptoms, lower abdominal symptoms, with a master health checkup detected PSA of 101 with a good performance status, I would say. He underwent a CT scan which revealed an enlarged prostate with suspicious prostatic lesion with multiple metastatic deposits in the lumbar spine, bilateral lung parenchyma, small, all abnormal sites of nodal metastasis as well. So he was subsequently referred to us, where we did a PSMA PET CT scan along with a biopsy as well. He had a Gleason 5+5, Gleason 10, that is, with perineural invasion, LVI, and the subsequent IHC which we did not document any neuroendocrine features. We also did a PSMA PET CT scan which showed multiple PSMA with lung lesions of variable sizes with multiple lymph nodes and multiple skeletal metastatic lesions as well. So again, a 71-year-old gentleman with extensive metastatic disease with unusual metastatic sites in the lung as well as non-territory lymph nodal metastasis. Next slide, please. So I think coming to the genetic testing part of it, do you think that this is a candidate for genetic testing right away, or would you like to wait? I think I will ask Dr. Amandeep if he has come back. Amandeep? Dr. Preetham?
Sir, although this would be not an upfront case where we do an genetic testing like coming with a metastatic disease, but in the present era, we have a lot of array of drugs with an olaparib which has shown good response. And as Rajesh said, we may lose a specimen later on when we if we're not doing an upfront. So probably he may help in doing an genetic testing early in the disease and right now. And we can also, it is also helpful when we want to use an olaparib in the later part of the treatment. Yes, sir, we can do an genetic testing in him right now.
Right. Dr. Uday, would you want to do a prostate biopsy, or would you also request your IR colleague to do a lung biopsy in this case as well?
So as we have seen a good presentation from Dr. Tejinder sir, that in spite of this prostatic biopsy, the testing means ratio of diagnosing this gene panel testings are higher in the lymph nodes and the other tissues like lung and liver parenchyma. Definitely, I would like, in spite of this prostate also, I would like to take a biopsy from this lung or liver, other sites, not from bone.
Not from bone, obvious. Yeah, correct. So, do you have now? I mean, now that HRI testing is available, have you sat down with your pathology colleagues and created a specific workflow, or it is again only need-based requests that are generated from your side?
So frankly speaking, means we don't get such sort of patients. Like affordability is the most cost constraint is the one of the major issue, and but like if the cost constraint is not an issue, definitely I would like to continue with this.
Okay.
Yeah.
So, Dr. Rajesh, what would be the preferred sample in case of unsuccessful tissue test? So you've done a prostate biopsy, you have done a lung biopsy.
The best one is lymph node.
Yeah, lymph
The best
node.
one is lymph node. Lung is not a, preferred organ. The best one is lymph node or any visceral, solid visceral organ like liver. And after that, the prostate itself. And the least one is the bony mets.
Yeah. So, no, you have done this sampling and it has come back as negative. So, would you like to consider germline testing in these patients where
Yes.
the somatic tissue testing negative, or would
Yes.
you assume that since the somatic test is reported negative, there is a less likelihood of non-HRR related disease?
No, I would like to get germline also, sir. Better.
Yeah. So probably when somatic testing is negative and you have a strong and compelling indication regarding HRR mutational HRD present, I think germline would also act as a good surrogate. I think the company has also introduced circulating cells. Has anybody in the panel tried CTC in these settings?
Yes, sir.
What has
We
been
have
your
tried.
Dr. Rajesh?
We are waiting for the results. Recently, only they started. Previously, they used to sponsor only the tissue,
Yeah,
not the circulating tumor cell.
correct.
We're waiting for the reports.
Correct. Next slide, please. I think these are the indications for germline testing in patients with prostate cancer. The initial slide showed the indications for somatic testing. This is for germline testing. High risk, very high risk regional or metastatic prostate cancer, patients with Ashkenazi Jewish ancestry, a positive history of family cancer, and a family history of high risk germline mutations, especially in the BRCA1 and 2, as well as the Lynch mutations. And those patients who have a cribriform histology, which is a surrogate indicator of genomic instability. Next slide, please. Next slide. I'll just skip all these. I think these have all been very extensively dealt by Dr. Tejinder. Next slide, please. Hello, am I audible?
Yes, sir.
Yeah, next slide, please. Next slide. I think we'll skip all of this. Next slide. Yeah, so coming back to our patient, the patient received 2 subcutaneous injections of Zoladex, Goserelin, 3 months apart, and the PSA level after the first and second injections were 19.25 and 89 nanograms per ml. The testosterone level assessment revealed the testosterone to be in castration level. So this is a patient who just received ADT alone and no added treatments. So I think all of us do agree that this is probably not the best way to treat this patient. Now that this patient has progressed on to CRPC in a short period of time, about 6 months. What next? Dr. Preetham?
Yes, sir. With present with an high volume disease, and then he has also progressed within such a short period of time. I would always prefer for an docetaxel in this patient, sir. And also, it should have a good ECOG status.
Okay. Okay. Next slide, please. So I think all these are options, but considering that he has a heavy metastatic burden, and if he has a good performance status, docetaxel will be the way forward. Next slide, please. I think I'll skip all these slides. Next slide, please. Next slide. Next slide. So, Dr. Vinay, I wanted to ask you 2 questions specifically. One is, if this patient had only nodal mets with one-off pulmonary met here and there, would you consider him oligometastatic, and would you consider giving radical radiotherapy to the prostate by going by the Stampede trial?
No, considering this patient has a visceral mets, so I don't think he is the right candidate for prostate-directed therapy. Yes, if it is a low metastatic, only less than say 5 sites of bone lesions and limited nodal lesions, then I would have considered for prostate-directed therapy, but not in this case, since he has a visceral mets. Is not the right candidate.
Not the right candidate. Now, sir, I would like to know about your experience regarding radiotherapy in oligometastatic disease. Have you been doing it, and how have been the results?
No, we have been done hardly 2 cases till now, as of now, in oligometastasis, where we had patients like with 1 or 2 bone mets, mainly in the axial bone mets. So we have directed radiotherapy to the prostate as well as the metastatic site. So
Okay.
metastatic directed therapy. So we have decent results, but long-term results I don't remember. I don't have presently. But yes, we have not treated only the prostate, but we have treated the metastatic directed therapy, the bone sites also.
I think it only makes sense because when the trial published, they were looking at all comers, and only a subgroup analysis showed that radiotherapy is beneficial in low volume disease.
Low volume disease. That's right.
Only they had given metastasis directed therapy, I think the results would be only better.
Correct.
So yeah. So I think that's a key point. We need to understand, especially the urologists, that oligometastatic disease can still be attempted with radical radiotherapy with a reasonable chance of cure, if not cure, at least reasonably longer overall survival. So it generally skips the urologist's minds that metastatic is metastatic. So we'll have to really discriminate whether these patients are radiotherapy worthy as well. So Dr. Vinay, I would like to continue with you. In your practice in metastatic disease, when do you consider bone strengthening agents? Which drug do you use, and how often do you use them?
Sorry, I didn't get you, sir. Which radionuclide? Did you ask radionuclide?
Not radionuclide, sir. Bone strengthening agents.
Bone strengthening agents. So all metastatic, with bone metastasis, we are using bone strengthening agents, preferably this zoledronic acid on monthly basis. Invariably, all metastatic diseases we are treating with zoledronic acid.
Zoledronic acid. How long do you consider treating them, sir? Or
at least 1 year.
At least 1 year. Okay. Okay. Dr. Gautam, do you think he's right now, this patient right now is a candidate for chemotherapy or any other alternative therapy like lutetium therapy?
Sir, this patient should be offered chemotherapy if he is fit. Lutetium PSMA is recommended as per the Vision trial, and it included patients who have at least progressed on a taxane and NHA. So currently he has only received the ADT. So as per the trial, he is not a candidate for lutetium PSA. We have used for some patients who are not fit for chemotherapy and who are not fit for other agents also. So if he is fit for chemotherapy, we should go first for the chemotherapy and plus or minus radiotherapy to the painful sites basically.
Thank you. Next slide. Yeah. I think we are running short of time, so I will probably not delve too much on these. What has been shown is that denosumab, rank ligand inhibitors, are much better compared to zoledronic acid, but most of us are conventionally used to using zoledronic acid as far as cost constraints are concerned. But probably the time to first skeletal related event and a progression of a skeletal lesion is more delayed when we use denosumab over zoledronic acid. So coming back to our patient, this patient went on to receive abiraterone. He was reluctant for chemotherapy. That is the main reason why he did not receive chemotherapy in the first instance. He received abiraterone along with prednisolone and zoledronic acid. A PSMA PET CT scan performed in after a year showed an increase in PSMA avidity in the skeletal lesions, and the patient was scheduled for EBRT to the painful areas. Dr. Vinay again. Sir, have you encountered PSA drop after treating bone lesions?
No, we don't perform PSA. Generally, these patients after palliative radiation, they go to, medical oncologists, but I am not really sure about, because we don't follow with the patients.
Okay. Dr. Gautam, do you see a transient PSA drop in patients who just received palliative RT?
No, so actually we don't do actually after palliative RT. These patients are asked to do PSA after some cycles of chemotherapy or on a follow-up.
Okay.
So
this is just out of curiosity I asked, because I know if all these disease, which is because a painful site is probably the most active disease site as well, assuming because it is to the patient. So is there a possibility that by giving directed therapy like radiotherapy, if there could be some level of PSA response? Just a curious question. I know it doesn't have any scientific basis. Next slide.
Yeah, we have never asked PSA immediately after radiation.
Correct. So now he has progressed on abiraterone. This was in this is an old case, 2017. Now, do you think that there is patient is still unwilling for chemotherapy? He has progressed on abiraterone. Would you like to consider HRR mutational testing now, or go ahead with enzalutamide? Dr. Gautam?
Sir, if the patient is willing for HRR testing, it should be done as soon as possible, and the report will take approximately 2 to 3 weeks in India basically. So if he is not symptomatic, we can start after 2 to 3 weeks. If he is symptomatic, we can start with if not chemotherapy, we can do other tests like MSI and MSI and MMR testing, and other options are, after getting the HRR testing, we can start with olaparib if it is mutated, and if he is not willing for all of this, we can consider for lutetium PSMA.
Lutetium PSMA. Okay. I'm sure all of us have used it. So how often have you used phosphosterol, HORN1 in particular, and what is your experience with it?
Sorry, sir, I didn't get it.
HORN1. Phosphosterol.
Therapy, sir.
HORN1,
sir. Actually, we have not used much basically. For few patients, actually, I think 2 or 3, because this we have got a lot of drugs in hand before the patient progresses. So we have used for quite a few patients, but for these patients, we usually get the echo done. We start on aspirin because it is a basically thrombotic agent. So there is a risk associated with it, and it is not associated with improvement in OS basically. So since we have got a lot of agents in hand, we rarely use it nowadays.
Yeah, can I take a parallel opinion from the urology
Yeah.
colleagues? Srikanth, any opinion?
Yes. So my teacher, Dr. Jagdish Kulkarni, used to use a lot of one, especially for those patients who are not affording. So we used to give 120 milligram, and we used to start them on antiplatelets also. And as Preetham said, there were a lot of thromboembolic events, and we also saw cardiac events like cardiopulmonary events from DVT leading to pulmonary embolism.
Okay, but do you still consider using it at some point of time in your treatment plan, or you have given it up?
Only when patient is not affording rest of the other agents and like very low poor income class, then we use one.
Okay. One quick
Yes, sir.
opinion as well.
Yes, sir. Can I say something, sir?
Yeah, yes.
Yes, sir. So we have used oral metronomic chemotherapy for few patients who are not affording, who are very, who are in basically very poor economic strata. And we have seen that if the oral metronomic chemotherapy used in the earlier line of therapy, it gives good result. Basically, we use it in a later line of therapy when we have exhausted the chemotherapy, hormone therapy, lutetium PSMA. So the results are bad for few patients who have used in earlier lines, and it has given a good result. One patient had a PFS of approximately 4 years on the OMCT only.
Yeah.
So
Currently, so that you mentioned, I have to tell you that we have been doing an RCT. We have already accrued about 38 patients. We are using metronomic chemotherapy immediately after completion of docetaxel in those patients who have shown
yes, sir.
a response to docetaxel with a PSA response of more than 50%, who have maintained a negligible toxicity profile during their chemotherapeutic regimen. We have been running this for about 2.5 years now, and like you mentioned, a lot of patients are doing well. So only time will tell. We want to accrue 100 patients and then see how it goes. So I'm glad that somebody else is also doing it on similar lines. So I think we are running behind schedule. I would like to stop at this point in time. Any comments from the panelists?
Sir, can I say something? Yeah.
Yeah.
Sir, regarding bone strengthening agents in metastatic HSPC.
HSPC.
Yeah, in metastatic HSPC, only if the DEXA scan shows if T-score less than minus 2.5 in osteoporotic range, then only to use.
Yeah.
The two initial challenging with the vitamin D and calcium. And, at 3 months, zoledronic acid, again at 12 months, if there is osteoporotic range. Otherwise, we don't need to use anything in HSPC. In CRPC, once a month for 12 months, the zoledronic acid or denosumab. But after 12 months, no data about it.
I think the recommendation is up to 24 months and not beyond 24 months.
Yes.
But what I feel is, if cost is not a constraint, we should strongly consider denosumab. We don't do it because most of our treatments are not affordable. I think zoledronic acid really, if you look at the data available, really does not alter the skeletal related events significantly. It is more like that we are covering it up as a protocol rather than having any major benefit. Having said that, I also use zoledronic acid mostly on my patients because of cost constraints. I thought I'll just bring this up during the discussion so that wherever possible we should start using denosumab.
Yes.
Any other comments from the panelists, or can we close? Yeah, I think I thank all my panelists for actively contributing for enhancement. edge of management of prostate cancer patients. I really appreciate your participation and time. May I now request Srivatsa sir to kindly give the closing remarks, sir.